So today's presenters are, in addition to myself, we have Steve Losey of Losey and Cahill. And I just want to recognize Steve. He's put a ton of effort into this over the last week and a half, and it's, as I've seen it come together, it's very impressive. So thank you, Steve, for doing that. And I just have to feel that as a consortium, we couldn't be more fortunate than to have Losey and Cahill as our consultant and providing this time and energy for educating our board and helping us be better at directing and protecting the organization. We also have Beth Miller from Excelis, who most of you know, and Megan Feely from PROACT, and they're here as resource people, so they're going to jump in whenever they have an opportunity to add some color to Steve's slides. I also want to acknowledge Jim Blizzard, who's up probably behind me right now, who's videotaping this and trying to keep track of all the sound activity. So thank you, Jim. Also, Michelle Potteroff, who you all know and has been such a strong supporter and someone we really lean on in the consortium to make sure all administrative details are handled. So with that, what I'd like to do is go back to having the participants introduce themselves. So we'll go around the table first and then just say your name and what your affiliation is, and then I'm going to pick the handheld mic up and give it to the people sitting off to the side so they can speak into the mic, and then we'll get started. So go with Ann Ryder.
I'm forced to take this position. Ann Ryder, Supervisor of the Town of Enfield.
My name is Laura Shawley, and I'm from the Town of Danby and on the Board of Directors.
I'm Chuck Rankin, Clerk Treasurer Administrator for the Village of Groton. Also work for the Town of Groton, and I am the Secretary of the Consortium.
I'm Betty Conger. I'm a trustee for the board in the Village of Groton.
Charmaine Rumgay, bookkeeper for the Town of Lansing.
Mike Murphy, trustee, Dryden Village.
Steve Thayer, controller for the City of Ithaca, also chair of the Audit and Finance Committee and CFO for the consortium.
Judy Drake, Human Resources for the Town of Ithaca and chair of the Board of Directors.
Debbie Kelly, Town of Ithaca. I'm also on Own Your Own Health Committee.
Margie Becker, I'm with the City of Cortland Wastewater, SEIU member.
Kate DeVoe from Tompkins County Public Library.
Teresa Viza, labor rep, Tompkins County Public Library.
Peter Salton, consortium board member, trustee of the Village of Cayuga Heights. I'm also on the Audit and Finance Committee.
Carissa Parlato, Town of Ulysses, Town Clerk.
I'm Nancy Zahler from the Town of Ulysses Board and on the Consortium Board and the Wellness Committee.
I'm Deborah Cipolla-Dennis. I'm on the Town Board at the Town of Dryden, and I'm also on the board for the Consortium.
Steve Losey from Losey and Cahill, consultant, works with the consortium.
Beth Miller from Blue Cross Blue Shield.
Megan Feely with PROACT.
I'm Joan Foote. I'm general manager of Bolton Point.
I'm Jim Bauer, UAW 2300 representative from Bolton Point, and also labor's representative for the Board of Directors.
Hugh Trim from Bolton Point Water, also with UAW 2300 shop steward.
I'm Joe Mariana, the county administrator.
Shelley Michelle Nunn, Director of Human Resources for the City of Ithaca, and I sit on the Joint Committee.
I'm Eric Snow, representative from the Town of Virgil.
Lisa Christian, Principal Account Clerk for the Consortium.
Beverly Chin, Human Services Coalition, and I also sit on the Own Your Own Health Committee.
Phil Van Wormeren with the City of Ithaca CSEA, and I chair the Joint Committee.
Matt Cook with the City of Cortland.
Mike Catalano, City of Portland Police Chief.
Rorden Hart, trustee from the Village of Trumansburg and vice chair of the consortium.
Bill Goodman, Ithaca Town Supervisor.
All right, so now we all have our voice and we've used it, so please feel free to ask questions. I would just say that if questions are asked, speak into the microphone so we can record it. And for those that are sitting without a microphone in front of them, whoever the question is asked of will repeat the question so we can have it on the tape that way. Right, moving right along, we exist because large and small municipalities can come together, large and small employers can come together due to Article 47. And this allows us to join as our own community-rated risk pool. And this is important because for the smaller municipalities, this is the only option other than the community-rated product in the private sector. This slide reviews some of the basic requirements of being in Article 47. There's a municipal cooperative agreement that each municipality signs on to. We also have to be required to create 2 reserves that are required by the state law. And finally, there is also a role for labor, and that is through the Joint Committee, as well as there are currently 3 directors on the Board of Directors. The consortium started on, received our certificate on 10/1/2010 and started operations in 2011. And we were the first startup Article 47 since the law was created in 1993. This is a list of our current members. There are 20 municipal partners. 4 of them have more than 50 employees and 16 have less. But we're all saving money on premiums. This is by providing, and we're also providing our employees with a stable product. And finally, we have an excellent service from our third-party administrators, Excelis and ProAct, that we are still enjoying. This slide is important because we'll be talking about covered lives and contracts throughout the morning this morning. But this slide shows the growth and change in both covered lives and contracts. You'll see a big bump in 2013. This is when the City of Cortland and the Town of Lansing joined the consortium. This slide shows the revenue. It's a pie chart. This is for 2015, showing that 97% of our revenue comes from premium. And whenever we are talking about premium development today, it's important. This is actually good in that it's very predictable. And also, it makes the calculation quite easy when you know where most of your revenue is coming from. This slide is of the expenses for 2015, and you'll see that 92.6% of our expenses pay for claims, and this is a very efficient model. Beth Miller says this every time she gets a chance, that this is an envy for most insurance companies for sure. And this is the reason why all participants and members are saving money through the consortium. This slide shows that having a large risk pool is good for predictability. The blue line is the cumulative claims predictions since we started. This has been based on our budget. And the red is our actual claims costs for those months. And when the red line is under the blue line, which it is consistently, then we are bringing more in premium than we're paying in expenses, which allows us to build reserves and reduce premium cost or offset some of that. And this slide just shows the difference between actual premium and actual expenses, revenues and expenses. And you'll see that in 2011, the first year, we were very close. And this was because we had to build a $3 million incurred but not reported reserve. So that was an expense we had to include. In subsequent years, we only have to bump that up by as much as our claims have gone up, and it's not a big lift. And so you can see we started actually putting money in the bank in 2012 and beyond. The other thing that this slide shows is that in 2015, that the expenses, the red line, are actually lower than they were in 2014, which is an anomaly. That's not what you would typically expect because we did not see a decrease in number of members, covered lives. And this allowed us to actually decrease the premium rate for 2016 to 3% increase as opposed to the 5% that we were projecting earlier in the year.
So, Don, question. Go back to this previous slide. And so if we were increasing income to build those reserves in the early years, so why is it in 15? I understood your explanation about why the red line is less, but the blue line is bigger, not only because the red line is less, but it's bigger. So why are we continuing to increase?
Sure. The reason why that we continue to increase is that experience throughout our area, and probably mostly nationwide, is that healthcare costs are going up roughly 8% a year. And there's not a reason to think that our population is different than the rest of the population in central New York. And so whenever we set our budget, we set a budget based on premium costs or claims costs going up 8% over what they were the year before. And so that's why the premiums are up there. We did not know that we were not going to be having that kind of experience in 2015. I will say that the Finance Committee and the board does a 5-year pro forma outlook for the next 5 years. And in doing that, this past year, we started using some of our fund balance to offset premium. And we'll see in a future slide that we're looking at premium increases of 5% over the next 3 years moving out. Again, using some of that fund balance to offset premium. We cannot give premium back to, or the fund balance back to stockholders other than through premium decrease. And that's our strategy. So this slide shows just the amount that we've had in the different reserves. The bottom one, the incurred but not reported reserve, that is a statutory reserve required by the Department of Financial Services. The fourth from up from the bottom, called capital surplus account, is also a statutory reserve required by the Department of Financial Services. The catastrophic claim reserve is one that we created to cover large claims should they come through. And the rate stabilization reserve we just started this past year, and that is to offset premium increases. The second one down from the top shows adjustments to the incurred but not reported. So this is the amount that we're adding to the IBNR reserve each year to keep our IBNR current with our required 12% of paid claims. And the top one, which shows the big spike in unencumbered fund balance, and we were not expecting to have that blue line at the top for 2015 being anywhere near as big as it is, but because of the claim experience last year, it was that large. This just shows quickly our premium budget increases for premium, starting out at 9.5%. And this was actually the experience that all our members were seeing collectively before we started the consortium, when we were planning on doing 9.5% for the first 3 years, and then we would take a look and see where we went from there. You can see that in 2013, we actually decreased down to 9%. And during that time, we also, at the end of that year, paid back all the capitalization that all our initial 13 members had paid in. So we were, at that time, you could see we were developing enough reserves to be able to be strong enough to be able to pay back. Then you see in 2014, we dropped to 8%, 2015, 5%, and 2016, 3%. And our pro forma analysis shows us at 5% as a target for the next 3 years. The next column over shows information that we were able to gather from the data from the Department of Financial Services showing Excella small group PPO rates. They were increasing over that same timeline from 2011 to 2016 at the rate of 10.5%, and we were increasing at the rate of 7.33. So the 10.5% is in keeping with the 9.5 that we'd originally budgeted to start out the consortium. And this, it's the slide that that Steve developed many years ago, but it's still very valid. We are all tied together by a benefit plan, and that's the benefit plan that we have with our as members, as well as with the health insurance company, as well as our providers. And so, as a patient, a provider, and the TPA. And through the insurance plan, we're all tied together through the benefit plan. And that's what's critical about premiums and the previous retreat. So with that, I'm going to turn it over, if there are any other questions, to I see Joe back behind Steve, to Steve Losey. And Steve,
well, Joe can come up and do the presentation if you want.
I don't think he wants to. I'm going to hand you this. I'm going to hand you the mouse as well.
All right. All right, good morning, everybody. what we're going to try to do is simplify and explain the process we go through in terms of developing rates. Whoops, what happened there? Oh, you just moved it forward. Okay. And we're going to try to start this with some of the basics. Now, unlike your household budget or maybe even your municipality's budget or even most businesses, health insurance rate setting kind of is backwards from what you would normally do. Normally, you would say, okay, how much revenue do I have coming in, and that dictates how much I spend. With health insurance and with running the consortium, we have to determine how much are we going to spend, and that dictates how much we need to bring in. So it's a little bit backwards from what you normally think of when you're developing budgets and developing expense expectations. So with that, the first slide that we presented in terms of the premium rate development has to do with the overall plan expenses. And as Don mentioned earlier in the presentation, we're spending about 92.4% of our plan expenses on claims. And that's to pay the benefits of the members. So the money going out to physicians, hospitals, other medical practitioners, for all the covered benefits under the plan, we're spending over 92 cents on the dollar. That means we're spending less than 8 cents on the dollar for everything else. Administrative overhead, and that includes not only ProAct fees, Excelis fees, we have actuaries working on the plan, my fee as a consultant, we have legal representation, we have an executive director, we have auditors, we have all kinds of other professional support. We do have some ancillary expenses in terms of insurances to protect the board of directors and some other things that go on. But all that told together is less than 8%. Just to kind of give you a sense of what that means, in the insurance industry for a large group health plan, which obviously the consortium would be considered, in order to be considered to have a reasonable, what they call medical loss ratio, so the amount of claims divided by the amount of premium in terms of percent, that number has to be 85% or greater, which means that you can spend up to 15% on administrative overhead. We're spending less than half of that in the consortium. For the small groups in the room, that can be as great, or as low as, I should say, 80% for community rated programs. So 20% could be used for administrative overhead, which could include profit, et cetera, et cetera. So again, our program is running at 92.4 and 7.6. It's extremely efficient from that perspective. The other thing that we have to consider in terms of our expense budget, and Don mentioned this as well, is the liability adjustment. Every year, we have to make sure our reserves are at an appropriate level to meet our statutory requirements. Our statutory requirements for incurred but not reported claims is 12% of expected incurred claims for the year. And for those of you who may not be aware of what that means, we have to have a sum of money basically in the bank today to cover all claims that were incurred up to today. They'll be paid at some point after today. So if for some reason, all of a sudden the board of directors decided that as of May 10th, 2016, we're going to cease operations, we know we have a lot of services that have been rendered to members that haven't come through the system yet, whether they haven't been billed by the medical community, whether ProAct or Excelis hasn't adjudicated those claims yet, whatever the case may be. That's what that IBNR represents. That sum of money to protect the members' benefits for everything incurred while the consortium is operating. Capital surplus reserve, another statutory reserve, is really just there to help protect the cash flow of the group. It's 5% of premium income each year, and that basically is set aside in case we have an anomaly like we had last year as an example, but in the reverse. Last year, our claims expense was actually lower than the year before, which is not heard of today. You don't see claims going down. So we didn't expect that. The reverse could happen at any point in time. We could project claims being X, and we could miss the mark by 4 or 5%, and that money is there to help protect the cash flow. Now, we have some other reserves that we set up to additionally protect us, but suffice it to say, we're very well funded at this time. In terms of trend, and Don mentioned that 8% number, where we get that from for this particular group is looking at your paid claims historically and trying to predict what's going to happen in the future. And this is one of the models that we happen to use. It's a least squares linear regression model. It's a statistical model. Basically just takes our historical data and then kind of looks for the midpoint amongst that data and projects out going forward where we think we're going to be. Based on the history of the consortium dating back to April of 2011, and the reason we use April of 2011 is because the first couple of months of the consortium we don't consider to be mature or credible months of paid claims. So we throw those out of the equation. and we start when we feel that we became mature as a group, and that was around April. And we go all the way through the most recent data in March of 2016, and we see that our average annual increase has been about 7.65%. So the 8% number is roughly what we would feel our normal trend would be going forward. And with the rate increases that Don showed, one of the things that we're trying to do is mitigate the rate increase each year using some of the fund balance that we've accumulated up until now to hopefully keep a low, steady rate of growth in terms of premium instead of having wild fluctuations. So that is also one of the things that we try to build into our modeling as we look at our expenses and look at going forward. In terms of the expense budget, real simple. I didn't want to give you every single line item. Certainly, if you want to see that detail, any one of the meetings, we do provide that, and certainly it's online. But in terms of our expense budget, we're looking at about $37.3 million in terms of total revenue needed to cover all the expenses and our liability adjustments for 2016. That's kind of our number that we need to get to in terms of a revenue projection. So that's what our target was when we started the year in terms of looking at the budget. In terms of our projected revenue for the year, now again, we had an anomaly last year in terms of lower paid claims expense than we had anticipated. That carried through to the beginning of this year. So you'll see our expense projection still is a little bit below our revenue projection for this particular year. But we're getting close to that break-even point. And once we do start to slide the other way and start using some fund balance, we really have to be careful on how we manage that so we don't go too far down. And then results in a much larger premium increase than we would otherwise have. But in terms of our rate premium, we're looking at generating about $38.7 million in income for 2016. Interest, we do get a little bit of interest income, not much. At $13,000, you think you'd get more than that if you got $20 million in the bank, but unfortunately not today. We do get prescription drug rebates at about $265,000 annually. All said and wrapped up together, about $39 in total income we expect to have in 2016, and 99.29% of that is directly related to premium. Now that's premium in combination between what the employers pay and what the employees pay in terms of contributions.
Steve?
Yes.
Is there a demographic change in the employees? Are more baby boomers retiring? We're hiring younger people, and that's why utilization is less?
I don't believe that has weighed into this because of the fact that most of the municipalities, even though they started turning over some of their employees, our retiree pool continues to grow. So from an average age perspective, we've not really seen much change in terms of the total population today. When we analyzed it, it really had to do with large losses. We didn't have as many large losses in 2015 as we had experienced in prior years. I think it was in 2012. We had one person that exceeded $1 million in claims. And we just, for whatever reason, we haven't had that the last 2 years. And continuing into this year. So we've been very fortunate from that perspective. We think we're just having a good cycle in terms of claims. It is very cyclical. We could turn around at any point in time and start to see it spike up. But as of right now, we don't think it's an age-based thing. It's more of a risk, catastrophic kind of loss thing that led to that. In terms of trying to get an understanding of what our average cost is per person, basically what we do is we take the amount of expense budget, $37.3 million, we rounded it to keep it simple. We know we have 5,028 covered lives, roughly. That's our average for 2016. In terms of expense, that's about $7,400 per person for the year. And that equates to over $600 per person a month. So when you look at rates, you say, oh, geez, why is the rate so high? Well, it's because we're spending over $600 a month per person in terms of their coverage, their benefits, and then all those other ancillary things on top of that, the administrative expenses, et cetera. But out of that $618, keep in mind that 92.3% of that or 4% of that is directly related to benefit. So we're as efficient as we can be, and it's still a very expensive proposition offering health insurance benefits to members today. In terms of kind of getting into the nitty-gritty of some of the rate development and some of the nuances that you'll see from plan to plan and some of the things that we had to go through as a group. One of the things that you first have to look at in terms of setting your rates is what types of premium tiers are you going to have. Generally in the insurance marketplace today, especially for small group, they have 4 tiers of rating. They have individual, they have employee plus spouse, employee plus child or children, and then family. When the consortium began its operation, we looked at what everybody had in terms of coverage. And this again dates all the way back to, we started in 2007. By the time we got it up and running, it was 2011. But as we were going through that process, the small municipalities typically had either individual and family or individual 2-person and family. The 2 large employers, the city of Ithaca and Tompkins County, had just individual and family. And historically, that had been pretty much the way most health insurances were, especially if you came from the old state health insurance program years and years ago. So when we established the premiums for the consortium, we did look at just individual and family. And we also looked at what the disparity in rate was. Individual is pretty much your base. And then basically from there, you tack on for your family coverage. And at the time when we started the consortium, the county's rate was a little less than 2.2 times the individual rate for family coverage. And that's kind of what we moved forward with in terms of our original rate setting model. And as an example of that, you'll see here the PPO medical rates for the consortium. This is 2016 rates for a $10 copay, $15 copay, $20 copay. And you'll see that over on the far right-hand side, the ratio's a little less than 2.17 today. Some of that has to do with rounding over the years and things of that nature. But we've kind of held close to that 2.17 rate ratio for our quote-unquote old-style plans that we have available through the consortium. When we look to develop the quote-unquote metal level plans, and these are the plans that we refer to as the platinum, the gold, the silver, and the bronze, we looked at establishing a rate ratio that was more consistent with what you would find out in the insurance marketplace. So we used a rate ratio of 2.6 times the individual rate for family in terms of developing these particular programs. And that's a little bit more consistent with what you would find in terms of health insurance programs offered today. Another factor that you can look at in terms of the rate setting and what ratios make sense is the Cadillac tax. For those of you who aren't aware, the Affordable Care Act has an excise tax function built into it. It was supposed to go into effect in 2018, it's now been pushed off to 2020, where any health insurance plan that has an individual rate annually higher than $10,200 and a family rate higher than $27,500 annually, for every dollar you go above that, there's a 40% or 40% excise tax that you have to pay the federal government. So what a lot of plans and actuaries have started to do is say, okay, we've got $10,200 for an individual, we got $27,500 for a family. What's the rate ratio between those two? And we've got it listed here. It's about 2.7, 2.696 to be exact. And they've started using that as their rate ratio to get the most efficient mechanism set up to try to avoid the Cadillac tax. And the reason they do that is because in an environment where you have, let's say in our older style plans where we're 2.17 times, our individual rate is going to be a little bit higher than the average in the marketplace for the same benefit given the same conditions we have. As a result, that particular rate may be closer to the Cadillac tax than we would like it going forward, whereas the family rate only being 2.17 times the individual rate may be a little bit lower than the average in terms of the industry, and as a result, it may not reach the Cadillac tax level. So in order to try to get that right balance, and that's something we may talk to the Finance Committee about as we move forward, and also the Board of Directors, you know, if we want to start to manipulate those individual and family factors slightly to make sure that we do avoid this Cadillac tax for anybody that's kind of stuck in those older plans, either for retiree group or for collectively bargained group that they can't get out of. So certainly something that we can talk about there.
So why is our individual rate higher? than the standard?
Because when we started the consortium, we started based off of the ratios that existed at that time, and the ratio was less than 2.2. So if your family rate is only 2.2 times your individual rate, that means your individual rate is going to be a little bit higher than the average industry-wide. If somebody else is using 2.6 times, their family rate is higher than ours, and as a result, their individual rate is going to be a little bit lower. Does that make sense?
Not to me,
Not
but
really.
that's okay.
All right.
But I actually have a more fundamental question.
Yes.
And when you were describing the way most insurance tiers are created, there is the member plus one. And that is something the town of Ulysses has been interested in, is having that option. I understand that the two largest employers don't want it for reasons I don't quite understand, but it means that we then don't have that as an option.
And that's actually a great question and a good segue, because let's talk a little bit about that right now. In terms of what the general insurance companies are offering today, and a lot of this has to do with when the Affordable Care Act was passed, and I'll give you a little health insurance rate 101 in terms of how some of this stuff developed over the years. Way back when, starting back in the 70s, most health insurance plans only had individual and family. And the reason they did that was because it kind of made sense. You have an individual, it's one person, you have family, it's multiple people, you have a different rate for those particular categories. And it kind of made sense from a statistical perspective and an actuarial perspective to do that. Along came health maintenance organizations in the mid to late 70s, and obviously they've been around for a long time now. As they started to develop their marketplace, they said, okay, how can we tap into some kind of a marketing tool that we can use that's a little bit different than what everybody else is doing? They said, let's develop a rate for two people. We'll call it a two-person rate. And that'll be cheaper than a family rate, and therefore we can market it, we can gain some market share that way. It has nothing to do with the statistical reality of the cost of two people's coverage. Because quite honestly, most two-person contracts in any analysis we've done are typically your older employees and younger retirees, quote-unquote empty nesters like myself. We tend to spend a lot more than the average person for health care coverage, and we tend to put in a lot more expense. So the idea that just because it's two people, it automatically would be cheaper is really a false premise. Really what you need to look at is who are you covering, not as much as how many am I covering. I will take 100 under 30 people all day to avoid the one over 55 person that has extensive medical problems. And that's just the reality of it. I mean, as we get older, we use more medical care. You see it, even though people get to the Medicare age, Medicare helps out a bit. If you add up all the coverage that they're getting and how much money they're spending, it's astronomical. So as we age, we do spend a lot more money. So having these different rate breakdowns really make no sense from a pure statistical or actuarial perspective in terms of rate development. It really just has to do with how they market these insurance products. And when you look at the Affordable Care Act products that are available through the Health Insurance Exchange, what we find is that when you start with the individual plan as your base, the member and spouse coverage is 2.00 times the individual rate. Well, if you're asking me, does a member and a spouse actually spend 2 times more than an individual typically in an average year? No. They spend a lot more than that. But for whatever reason, the rate ratios are set up this way. And again, it's probably more for a marketing reason than it has anything to do with true financial analysis. The member and the child or children at 1.7, it might make sense. I don't know. I've never really done that particular analysis directly to see if that makes sense. And then the family rate at 2.85. I'm going to show you some statistics that will show you that even that doesn't make sense. That the individual rate should probably even be less than the 2.85 of the family rate for a lot of reasons. And as we look to some of the statistics of the consortium to try to describe some of this a little bit further, we look at the average contract count and the average number of covered lives in the consortium over the years that we've been in existence. And you can see we've been pretty consistent. In terms of our average number of lives per contract, it's about 2.2. So for all the contracts and all the covered lives, if we divide it out, it's 2.2 times the number of contracts. That's how many covered lives we have. And that's pretty consistent. It's about what we see with most of our clients that we work with throughout New York State. They're 2.1 to 2.2 times. Is pretty consistent. Then you look at the average number of lives actually covered by a family plan, it's over 3. So again, when you look at that, you would say, oh, so the individual rate would be the base, and then the family rate would be 3 times that. That would make sense because that's the number of covered lives. But that's not the way, for whatever reason, the insurance industry has ever done it. And as a result of that, in order to stay competitive, we have to have rate ratios that are more in line with what they're doing in the private sector insurance marketplace to some extent. Looking even further into that, we say, okay, well, what about from a cost perspective? What is the individual plan cost versus a family plan cost on an annual basis from a medical, and we use medical in this particular example just as a quick analysis to see where we were. And you see even with the actual claims themselves, you'll find that the family is still more than 3 times the cost of an individual. So why wouldn't the family rate be 3 times more? Again, we need to make sure that our rates are similar to what's going on in the marketplace, so we're at a competitive advantage. We're more efficient, we believe, than the marketplace, and as a result, our rate should be lower. However, if we use these rate ratios, our individual rate would look great, and our family rate would look terrible. So as a result, we may not be as attractive to not only our existing members, but to other municipalities that might want to join down the road. So that's one of the reasons why we've used the ratios that we have used over the years. One, from a historical perspective with the 2.17, and then from a competitive balance perspective with the 2.6 for the newer plan models that we've developed. And again, I think that's something that we're going to talk about with the Audit and Finance Committee going forward, if we want to maybe make some small adjustments to that. The difficulty with making those small adjustments is that someone's going to be hurt and someone's going to be helped slightly by that occurring. Obviously, if we're having a really low rate increase at the same time, it helps a lot. So if we're going to make an adjustment, the next year or two would be the time to do it while we've experienced real positive growth. Going to use some of that fund balance to mitigate rate. It may be the time period to take a look at that and see if we want to adjust those going forward. In terms of a sample calculation, just to kind of give you an idea of what we might look at using a 2.6 as our ratio, and this assumes that everybody has the same exact coverage across the entire consortium, and we know we don't have that. We're going to get into that complexity here in a little bit. But if everybody had the same exact coverage in terms of the entire consortium, this is roughly what it would come out to be using a 2.6 as our rate ratio model. We'd have an individual rate of about $702, and we'd have a family rate of $1,825 roughly. And those are monthly rates that would accumulate up to $37.3 million in total revenue for the plan for the year, which was our target way back a few slides ago when we first started to look at those rate ratios. Just to show you that it does work out, we checked our math just to be on the safe side. And we'll show you here that with 979 individual contracts, it accumulates about $8.2 million in revenue. With about 1,327 family contracts, it accumulates a little over $29 million in revenue. Lo and behold, we get to $37.3 million. Using that, we're within 0.003% of our budget, and that's usually the way it works out. Obviously with rounding, and we don't take it out past a penny in terms of the rate. Sometimes even we round it off to the nearest dime. You're going to have some of that slight differential in there. It's only $1,000 off, so it's not too bad on $37 million. So that kind of gets you the basic understanding of how we got to kind of our individual and family rate. And as I mentioned, that was all kind of modeling based off of a best case scenario where everybody's got the same coverage and everybody's doing the same thing. Well, as we know, we have a lot of people not doing the same thing. We have a lot of different coverages in the consortium. I think at last count, in terms of our subgroup total, I want to say it was well over 100, and it might have been close to 130 different subgroups that we have within the consortium. We have 20 participating municipalities. And inside some of those, even some of those employers, we have obviously multiple plans that are being offered. So things that we have to look at in terms of determining rate for specific plans are these rate differentials or premium rate differentials. And there's a number of them. You know, these are the bulk of the main ones. You know, who's covered by the plan? What type of risk pool are we looking at? You know, demographics. Yeah, are we looking at only insuring young people that are fairly healthy? Are we looking at insuring people from, you know, age 1 to 100, like we are in the consortium? Are we only insuring Medicare age folks? Every demographic obviously has a little bit different risk that goes along with it, and as a result, they would have a different rate assumption applied to them. Projecting increases in paid claims and related expenses. You know, we talked a little bit about that. Obviously, every benefit plan, depending on how much it covers, is going to dictate a different level of paid claims for that particular plan for a year. And trying to come up with an understanding of what's going to happen from year to year with the programs can be challenging. Now, in the consortium, the one thing that we do, and this kind of protects everybody, we think in the long run, is we use a pooled approach in terms of this projected increase from year to year. So we look at the entire budget of the consortium. We apply whatever the increase in that budget is projected to be from one year to the next, evenly across all the premiums within the consortium. So we're not doing any type of risk adjustment internally inside the consortium where we're looking at one town versus a village or a village versus a city or the county versus everybody else. We're looking at it globally as one plan and everybody's rates going up similarly. So that particular increase is going to be consistent across the board for all the plans. The next one in terms of style of plan offered is a bit different. We have what we refer to as old style indemnity plans in the consortium, which are, you know, your typical paid in full hospital medical surgical coverage with some kind of a quote unquote major medical that picks up, you know, 80% after a deductible with maybe a prescription drug card or the drug may be under the major medical. Those are what we call kind of old style indemnity plans, kind of what most employers had back in the 90s for the most part. We do have some preferred provider organization plans, and those are typically still paid in full hospital, medical, surgical type of coverages, but instead of a deductible and coinsurance for those quote-unquote major medical type items, you're paying a copay, you know, a $10 copay for an office visit, et cetera, and you have a prescription drug card that goes along with it. We also do have, all the way on the far right there, HDHP plans, high deductible health plans. Now, when we built our quote-unquote metal level plans, the platinum, the gold, silver, and the bronze. The silver and the bronze were intended to be high deductible health plans. And those plans are kind of new to the marketplace. They're sometimes referred to as consumer-driven health plans. Basically, they typically have a much higher upfront deductible, so the member's paying a lot more out of pocket. As a result of that, members do have the opportunity to open up a health savings account to put money aside on a pre-tax basis to pay for some of their out-of-pocket expenses. And then there are other plans kind of in between the PPO and the high deductible plan that we don't currently have in the consortium because we can't have them. There's exclusive provider organization plans, which is like a PPO but a much smaller network. So your access would be limited to what physicians and hospitals you could go to. You know, for instance, we could develop an EPO plan that may be Cagle Medical Center only, as an example. Unfortunately, we can't have a plan that does not include an out-of-network benefit, and in the private sector, they can do that. So it would be like a PPO with a small network as opposed to an exclusive provider organization plan where there's no out-of-network benefit. And then there's HMO plans, health maintenance organization plans. Those are far different than what they once were. When they first started, they were kind of group-modeled HMOs where you would go to their offices for services. Nowadays, they're kind of like traditional insurance plans, except, again, most of them don't have an out-of-network benefit, which is pretty limiting for our members and something that probably wouldn't work out for us. How much does the plan pay? You know, that's kind of a general term for actuarial value. And we're going to talk a little bit about actuarial value as we go through some of the additional slides and some of the things. And we've talked about this with the metal level plans. You know, basically what the actuarial value is what percentage of the average person's medical care costs is that particular plan going to pay in a given year. And when we've talked about our metal level plans, a platinum plan picks up about 90% of the average person's medical care costs in a given year. The gold is at 80, silver is at 70, and bronze is at 60. In order to meet the shared employer responsibility under the Affordable Care Act, an employer has to provide at least a bronze level of coverage. So how much does a plan pay? It has to be at least 60% in order to qualify as an essential benefit plan providing essential coverage under the Affordable Care Act to meet your employer shared responsibility if you are a large employer. Is there any premium subsidization occurring? You know, whether we're getting some federal funding from the ACA, which we can, unfortunately, but they do get in the health insurance exchange. They also get those with the Medicare Advantage programs. They do get federal funding in those, which helps them with their rate setting. Is there any in-house competitive or marketing reasons for having some subsidization? Do we know that one rate is a little bit low because we're trying to move, you know, populations in a certain direction? Insurance companies do that all the time. When they have new products hit the marketplace, those rates tend to be a little bit soft in terms of what the true expense is, try to gain market share, and then over time they ratchet those up. Does the plan change behavior or purchasing decisions of the members? Are we driving any consumer decisions that are different than what they would otherwise make, therefore driving down the cost of the plan a little bit? Do we have any type of managed care involved in the program? Utilization review, you know, pre-certification, any types of controls over what's being spent, and then is wellness included as well? You know, all these things are elements that would force us to say, okay, you know, instead of having a rate at X, you know, if we have differences in each one of these categories or several of these categories, it would force us to say, oh, we need a different rate for this plan because of all these different intricacies that are involved and are a little bit different than the other plans. In addition, obviously, we're looking at demographics. Who are we covering? Are we covering employees only? Okay, that's one set of people that we could cover. Are we covering retirees as well? And if we are covering retirees, we're covering retirees under age 65 and those that are also Medicare aged. Are we covering spouses? A lot of people may say, well, of course you're covering spouses. If you have family coverage, you have to cover spouses. The reality is you don't have to cover spouses. There is no state or federal mandate that says if you have family coverage, you have to cover the spouse. Now, our plans do have spousal coverage, but a lot of employers, and you may have read this with UPS and a couple other ones, are moving away from that. They're saying, well, you know what, with the Affordable Care Act now, it requires that every adult has to have coverage, and as a result, their employer should be offering coverage, or if they don't have an employer, they should be getting coverage on their own. So it's really not our responsibility to provide spousal coverage anymore. So they're only providing now their employee and retiree and maybe dependent coverage. And obviously dependents come along too. You know, those would be any type of eligible children, whether they're, you know, natural born children or adopted or stepchildren or whatever the case may be. Certainly they're available for coverage. And now we're covering those folks up to the age of 26, which I don't know if they're really children at that point, but they do stay on the payroll a long time these days, I can tell you from personal experience. In terms of, you know, looking at our population a little bit closer and looking at some of the costs and how they can impact rate. This is from the 2015 PRO Act pharmacy utilization report for the year. And you can see the different levels of age groups, the number of eligible members in each, how much they spent per member, and then what the similar client spends, and it's out of PRO Act's database. Our data is the first three columns, first two columns after the age group distinction. So those are our actual eligible members and our actual spend per member. And you can see the difference. You know, everybody under the age of 19, no big deal. We're spending $37 a month for prescription drugs. Even up to 34, we're still only spending $34. So every person that we're insuring under the age of 34, which is almost 2,000 people, are spending less than probably $35 on average if you add those two groups up together. Then we start to get a little bit older, and we start to use up a little bit more. Now all of a sudden our blood pressure's high because we got kids, we got jobs, we have all kinds of taxes to pay. So now, boom, you know, at age 35, we're up to $141. Maybe we're on a cholesterol med because we can't watch our diet like me. Then at age 50, well, there's my category, okay, $217. Now we're probably on psych drugs too because we can't handle anything that's going on anymore. And then at age 65 and over, it goes up to $276. So you can see how demographics has a great impact on the amount that you're spending. That's why I said earlier, it really doesn't matter to me how many people I'm insuring. I really want to know who I'm insuring. I want to know who am I covering. Am I only covering 55 to 60-year-olds? I'm going to go bankrupt pretty quick because my rates are never going to be able to cover those folks. Am I covering people under the age of 40? That's great. I'm going to make a ton of money because I can have a rate below the market rate, and my demographics are that much better. I'm going to make a ton of money insuring those populations. So it really does have a big impact. And when you look at the over age 65 population, which I can just give you a feel for it, less than 15% of the covered lives, but more than 28% of the claims dollars. And that's kind of what we're looking at in rate development, from the consortium perspective and looking at the global expenses and then trying to figure out what's the best rating relationships between individuals and families and plans, et cetera. We're looking at all these different elements. In terms of a breakdown between medical and drug, and this is kind of give you a feel for why we have rates developed for each category of benefit, if you will. We basically have two major benefit categories, and they're represented here by ProAct and by Excelis. Prescription drugs, we spend about 27 cents on the dollar in terms of claims. Prescription drugs, and that has gone up over the years at a pretty good rate. And we're around 73 cents on the dollar in terms of medical expense. Certainly that tells us that there's two different segments to our benefits, and we need to look at the rating a little bit differently for each one of those categories. In terms of breaking down our rate, and we're going back to our hypothetical mean rate, if you will, for the consortium as a whole at $37.3 million in revenue, at the 701.81 for individual and the 1824.71 for family. And now we're breaking it down between medical and drug. And this kind of shows you the relationship and how we're building the rates. And when you look at the rate sheets that we developed for the consortium, we have the medical rates separate from the drug rates, and you have to combine the two to get to your full rate. This is kind of the process that we go through in order to get to that type of detail that you need to have for your programs and for what you're doing from a bargaining perspective, et cetera. In terms of the plan models that we have available through the consortium, I mentioned a little bit about this in an earlier slide, but I did want to emphasize this a little bit. We have the indemnity or traditional plans. We do have PPO plans. The PPO plans do include those metal level plans. They are considered preferred provider organization plans, especially the platinum and the gold plans. We do offer the high deductible health plan, which is the silver and the bronze. Health savings accounts are available to any employee that does utilize one of the high deductible health plans. And a lot of our employers do offer flex spending accounts. The difference between health savings accounts and flex spending accounts are immense. If you do not have a high deductible health plan, the best you can do for your employees is providing them a flexible spending account to cover some of their medical costs with pre-tax dollars. A flex spending account allows them to put up to $2,550 into an account pre-tax in a year that they can use for unreimbursed medical expense. They're only allowed to roll over up to $500 of that from year to year. So if they have a balance above $500, they would lose that. They would revert back to the employer. A health savings account is quite a bit different. I think the limit this year for health savings accounts is around $6,600 for a family in terms of what you can contribute on a pre-tax basis into your health savings account to cover your unreimbursed medical expenses. The rules are the same in terms of what you can use the money for in both of those accounts, the HSA and FSA. However, with the HSA, you're obviously putting in a lot more money. They do allow you to roll that money over from year to year so you can accumulate it over time. It's very well set up for younger employees who can obviously put some money aside. They don't have a lot of expense. They can build money up over time. It certainly helps if you're younger getting started in those programs. I've had a high deductible health plan with a health savings account for the last 7 or 8 years now. It's only been the last 2 years that I've been able to accumulate a good portion of my money and roll it over from year to year. Between kids with braces and other types of stuff going on, you end up spending a lot of it. So different types of programs, certainly good benefits to have available. But in terms of the plans that we offer in the consortium, the benefit plans are really the indemnity, the PPO, and the high deductible health plans are really the three main items that we do offer. From a medical plan perspective, we have gotten into a Medicare supplement plan, but for our discussions today, I'm not really going to get into too much detail about that today, but suffice to say, we do have that available. To kind of show you the relationship in cost and benefit between these plans, we put together a quick slide just to show some of the basics of a PPO plan versus an indemnity plan. A lot of you already know this, but for those of you who may be new to the process, we thought this might be helpful. Obviously, with the PPO plan, there's no deductible up front for in-network services. You're paying a copay for primary care and specialist services. There is an out-of-pocket maximum for prescription drug and for medical separately under our current programs. And you can see the rates down at the bottom. It's $641.38 for an individual and $1388.24 for a family. This is just the medical portion of the rate, so keep that in mind. It does not include drug. Under the sample indemnity plan, we have an upfront deductible of $100, but only for certain services. So only for those things that would be covered under the major medical. Again, the medical surgical stuff is all paid in full under that. We have a much lower out-of-pocket maximum. As a result, we do have a higher premium, $654.37. So because of the fact there's a little bit lower out-of-pocket expense, the member's paying a little bit less out-of-pocket in the year, they're going to have a little bit higher premium because their benefit's a little bit better. This is kind of a good example of really what we go through in terms of looking at every single benefit model and trying to get those relationships right in terms of the benefit it's providing and then the rate being commensurate with that benefit. And we do the same thing, with all the plans, and these are kind of the components that we look at. As I just mentioned, we look at in terms of variances in the medical plan. We see one plan's got a $100 deductible versus a $10 copay. It shows that the premium is about 2% higher than the $10 PPO copay as a result of the higher deductible and the lower out-of-pocket max. And again, just kind of a summation of what I tried to describe as we were going through it. From a prescription drug perspective, obviously we got to do the same thing. Not only are we looking at all the different medical plans that we have, but we may have 5 employers all with a $10 PPO program, and they may all have a different prescription drug setup that goes along with it. The main prescription drug models that we have under the consortium are what we refer to as 2-tier and 3-tier models. A 2-tier model is pretty simple. It's either a generic drug or it's a brand name drug. You pay one copay for generic, you pay a different copay for brand. Pretty simple. A 3-tier prescription drug model, a little more complex. Tier 1 is predominantly generics. There may be a brand drug that slips into Tier 1 every once in a while, but Tier 1 is predominantly generic. Tier 2 is what we refer to as preferred brand name drugs. And then Tier 3 is non-preferred brand name drugs. So an example here would be we may charge a copay of $5 for Tier 1, $15 for Tier 2, and then $30 for Tier 3. So now we're trying to drive consumers to look at, okay, what's this costing me in terms of what I'm getting? Are there other drug therapies available to me in my particular disease class that I can look at? And we're trying to build a little bit of consumerism. In the marketplace, a lot of companies have added a 4th tier. With the influx of specialty drugs and the high cost associated with those programs, a lot of companies have now added a 4th tier to the rating system, and a lot of times it's on a percentage. So you're paying a percentage of a very high dollar amount. Our current average, I believe, for specialty drugs is around $3,000 a month. We've had drugs as high as $60,000. I've seen approvals for drugs from $10,000 to $20,000 to $30,000 a month. So if you're paying a percentage of that, you're going to meet your out-of-pocket max pretty quickly. But companies have started to move to that because of the reaction to that high-cost claim area in terms of the specialty pharmaceuticals. We've not done that in the consortium yet. I don't know if we will ever get there. The municipal sector tends to move a lot slower, obviously, from a benefit perspective than does the private sector, but it's something you need to be aware of so that if people start asking you questions about what types of plans we offer and maybe why we don't offer other types of plans, you'll have some at least basis of understanding of that. In terms of a quick comparison of 2-tier versus 3-tier, again, this is just the drug rate. It's just a comparison of the drug plan, but we looked at 2 plans that we currently have in terms of 2-tier. Really should probably say 2-tier non-formulary, but we have a $2 generic copay and a $10 brand name copay with no copay under mail order. And then we're comparing that to a 3-tier program that has $5 tier 1, $15 tier 2, $30 tier 3, and then it has mail order at 2 times those levels for up to a 90-day supply, where retail's limited to a 30-day supply. You can see that there's some components that we have built into the 3-tier that the 2-tier does not have. The generic advantage program was referred to initially with Excellus. It's really now just a mandatory generic substitution program with maximal allowable cost. We do have prior authorization under the 3-tier, where you have to get prior approval for certain meds. We do have step therapy, and there are some quantity limits involved. Obviously, the 3-tier is going to cost the member a lot more money out of pocket. As a result, their rate is quite a bit lower than it would be for a 2-tier rate from a rating perspective for those particular programs. As I mentioned, with over 100 different models, we have a lot of different prescription drug plans that are available. But in terms of the variances, these are the things that we look at when we're going through the drug plans in terms of rate variance. Obviously, the retail pharmacy copay is one of the predominant things. That's where the majority of the drugs are filled. We look at the copayments under mail order, where we do have a bit of utilization there. Increased incentive to use generic medications. Obviously, if we've got a very high brand name copay, we're encouraging people to use generics. We're trying to alter people's buying behaviors in certain segments of these programs. Again, with the 3-tier, we're trying to drive people to more affordable brand name drugs, and even down to generics when they're available and when it's proper for their care. And then there's obviously those added managed care elements that are involved in those programs as well. Now that kind of gives you a little bit of, kind of the basics of the 101, if you will, of building kind of these premium plans and some of the variances that we're looking at. At this point, we're going to take a small break, and then we're going to get into a bit more detail, a bit more sophistication in terms of some of the rate model and how we build them. But right now, I'll turn it back over to Don.
Thank you, Steve. So that was a great background and foundation for how premiums are set.
I want to mention it's 3 minutes early.
and I am impressed, so good for you. Yeah. I see he's got his clock there. He's keeping track of it, so that's good. And I wanted to give Beth and Megan a chance to say any words of wisdom that they wanted to before we get started. And then I see that our photographer came in, so we'll have him get set up, and then we'll go from there. So please, Megan, Beth.
Go ahead, Megan. Put you on the spot. Well, I guess I'm not really sure what to say, but I'm, thankful to be here and, learn about the consortium, and, it's a great presentation that Steve put together, so thank you.
Perfect. Thank you all for attending the retreat. As Don said, it is our 3rd year. It's very exciting. You really learn a whole lot, maybe more than you want to know about the consortium, but it really gives you an idea of what is put into it and how it's come about. And Don is correct. At Blue Cross Blue Shield, you are lead, and you have a loss ratio incredible. There's 7 cents goes to paying admin, and the rest are board admissions and any costs, which is pretty amazing. We did the utilization review at the joint committee meeting. We actually are also going to be doing a high-level review at the next board meeting. So that information is very insightful as to what's happening with your claims. And then also I just wanted to mention both Megan and myself brought some information. Please feel free to take it. It's regarding your health and prescription drug coverage. And it's just ways that you can work within the plans that you have to save money. Thanks.
All right, so I think what we're going to do is let Steve go on to the next part and work on that. And maybe after we finish the next section, Steve will just take a little break for a group shot. And in the meantime, Michael will be around taking some action pictures as we're working together. Steve.
Thanks, Don. First, I just wanted to see if there were anybody had any follow-up questions from the first part of the presentation. Yeah, you had a couple minutes to think about it a little bit, and I don't know if anybody has any thoughts or comments or questions that they might want to get out now. If not, we'll certainly have some time at the end of the presentation, but I certainly want to make sure everybody gets their questions answered before we leave today. If you don't think of anything that you want to ask today and you think of it at some later date, if you get it to Don or myself, we'll make sure and get a response back to you as best we can and as quickly as we can. With that being said, I guess we'll move on to the next part where we get into a little bit more detail in terms of individual line item changes, in terms of premium, and what factors can be more impactful than others in terms of rate change and things of that nature. So the first thing we did is kind of gave a little bit of an example of a premium impact for two different types of plan changes. The first one is we're going to increase the generic copay for generic medications by $5. And then the second one is we're going to increase the emergency room visit copay by $50. Now, all the data that you see here was taken out of the year-end reports for either Excellus or ProAct. It's data for the entire consortium. We didn't break it down by, specific plans that we're going to be making these changes. Just looking kind of at, global impact of these different benefits and what it would mean from a rate perspective. Now, when you think about a $50 change versus a $5 change, you'd immediately think, oh, well, it's got to have more of a rate impact because it's a much higher dollar amount. Well, the reality is, a lot of it depends on the number of items or number of services that are involved in terms of the actual dollar value and then the rate impact that's associated with it. So when you look at the generic drugs, currently about 80% of all the medications filled for the consortium are filled with a generic medication. Last year, that was almost 62,000 scripts. So 6,801 scripts were generic. If we increase the copay by $5, in terms of a dollar-for-dollar value, in terms of number of scripts versus cost, that would return about $309,000 to the consortium. So the member would pick up $309,000 more, and the consortium would be picking up $309,000 less. The emergency room impact is a little bit different. We had 1,169 emergency room visits. If we just simply use that number of visits and think that that will continue on in the next year, and we increase that copay by $50, the impact there is just under $58,500 to $58,450. Now, the rate impact down below, you'll see the generic RX copay change would have a relative value in terms of rate impact of about 0.83%, and the emergency room copay change impact would be about 0.16%. So depending on what type of benefit you're talking about, the dollar value, how many services are performed or visits occur, obviously has a great weight on what happens with premium. Now, we didn't build a lot of factors in here because we'd also have to consider, well, if we're going to increase the emergency room copay by $50, obviously that may change people's behaviors. Instead of paying $50 more to go to the ER, maybe they would make a secondary decision, which would be, it's really not an emergent situation. We really could go to urgent care. Maybe I'll call my physicians. Maybe someone has some extended hours I could go see. So we didn't factor any of that in. It's just kind of a simple example of quantity versus amount being an important factor in terms of the rate change modeling.
Steve?
Yes.
How do you come up with the percentages? What was the calculation?
Basically, percentage of change versus overall rate for each category. So where's the previous slide here?
Second one down.
There it is. Sorry, couldn't see it. So the RX change was the $309,000 divided by the total amount of RX premium for the year, and then the emergency room copay was $58,000 divided by the total amount of medical premium for the year.
Thank you.
So Is this just an example, or is this a change that's being?
No, it's just an
Oh,
example.
okay.
Just an example. In terms of the rate impact items that, we would consider to be important as we go through an analysis like that, obviously, overall plan style versus the line item changes is important. How many people are going to be affected, either by number of services or number of items, population. How many services or items are affected globally? Does it change, alter buying patterns? I mentioned about the emergency room. Also, if we raise a brand name copay as an example, does that drive more people to use mail order? Or if we raise all the copays, does that drive more people to use generic? If we raise all the copays, does that drive more people to use mail order versus retail? Certainly buying habits are difficult to project, but they do come into play when you talk about these types of occurrences. Cost variance for different levels of service, utilization and case management oversight, and then obviously short-term, long-term impact. That one will come into play when we talk about things like wellness. What's the short-term impact versus the long-term impact? We all think about wellness a bit, and we think about it, from an intellectual perspective, it sounds like a good idea. It certainly makes sense. There's an upfront cost, but there may be a long-term benefit. So that's the kind of thing we're talking about there when we look at that. In terms of kind of giving you a little bit more insight into, kind of the steps that you might go through in looking at one of these equations, this, again, we're looking at something fairly simple, which is emergency room copay. And we try to keep the examples, pretty basic for today. We didn't want to get everybody lost kind of in the weeds on these. So we wanted to look at those things that were frequently used, that people understood, and things of that nature. So in terms of emergency room, current benefits paid in full, so we don't have a copay for ER, and this is, again, just an example. It's not something we're proposing. It's just a sample equation that we would go through. We're proposing that we would change the copay to $100 in this theoretical example. Number of services, we kept, the example simple with 1,000 as opposed to using the exact number that we had. A utilization impact, we're going to say that by increasing the copay by $100, we're actually going to drive about 10% less ER visits. So out of those 1,000 ER visits that we had, we figure that about 5% are going to go to the physician's office, about 5% may go to urgent care. Again, these are just theoretical numbers. They're not based on any true life example. It's just kind of a process more than a real life example that we're showing you. ER visit cost, this is kind of true. We do know that that's about $1,600. We know that an urgent visit costs about $260. We know that your average office visit is about $120. So all of these elements are going to come together to dictate how much of a variance we're going to see in rate as a result of this one change in ER copay. Now, in terms of going through the equation, and again, this is kind of a simplistic example, but it's something I think people can follow pretty easily. So again, we're talking about changing the ER copay by $100. We said that we would have 10% less ER visits. So instead of 1,000, we're going to have 900. We're going to decrease our exposure by $100 because the member is going to pick up a $100 copay. So we've decreased our cost expectation by $90,000. We also believe that we're going to drive 5% of the people to the urgent care that would otherwise have gone to the ER. That differential there, we have 50 visits that instead of being $1,600 are now $260 because the average cost for an urgent care visit is $260, average cost for ER is $1,600. That drives about $67,000 in savings. We also think that we're going to have about 5% of the population go to a regular office visit. So that $1,600 ER visit all of a sudden becomes a $120 office visit. That totals up to, $74,000 in cost reduction. Total cost reduction for this particular change, giving these elements, $231,000. We know our medical premium was $37.3 times the 73.2, which again, 73.2% of our total premium was medical. That gets us to the $27.3 million in terms of medical premium. $231,000 in savings divided by 27 $0.3 million in medical premium, gives us a rate adjustment of 0.846% in premium. And that should equate back to roughly what the number was in the prior slide. So that's kind of the process that we would go through in saying, okay, we want to look at this particular line item change. Now what we have to do is, when we're looking at complete, obviously sweeping changes amongst a particular medical plan, we have to couple all these things together. So we've got an ER change, we've got office visit copay change. We've got, visit limitation on, physical therapy. We've got other types of elements that are being dragged into this. So there's a lot of these individual calculations that go into a global benefit analysis on a benefit change going from, plan A to plan B. But it's a good example, and I think one that's pretty easily understood in terms of what the process would be in terms of these rate adjustments.
So Steve,
yes.
Is that what you did to compare a PPO $10 plan to a PPO $25 plan, is do this kind of scenario, and that's what made the difference in the rate structure?
Correct.
Okay.
Yes. And it's the same thing that Excelis would do as well. Their rating department historically would have done this for all these plans before they came into the consortium. The only thing that they may do that would be a little bit different than we would do sometimes, we talked about a little bit, they may have a marketing strategy reason why a rate may be set at a certain level.
Right.
For competitive balance reasons. I know that for a fact, when you look at the Affordable Care Act and the health insurance exchange rates, when those originally came out from all the insurance companies, they were all looking at each other to make sure that they were all kind of in the similar region to make sure from a competitive perspective that they were not only going to be able to sustain these programs, but that they'd be able to gain some market share. So that's something we obviously won't do. We're not going to have a rate that's too low just to gain some additional members in the consortium. We're never going to do that. In terms of a sample RX benefit change, in this particular program, we're looking at 2 3-tier prescription drug plans, one being 5/15/30, and then increasing to a 10/25/40. And this is kind of similar to what we have currently in some of our modeling for our various benefit plans in the consortium. Again, we're using some rough data from the consortium, kind of rounded off to keep examples kind of simple. But in terms of number of prescriptions, we've got about 62,000 in generic, we've got about 10,000 in preferred brand, and 4,200 in non-preferred brand. Our average cost for those different tiers, about $30 for a generic med, $326 for a preferred brand, and then $801 for non-preferred brand, and that includes specialty drug in this example. Obviously, you can see one of the reasons why a lot of companies, insurance companies and prescription benefit managers have gone to these 3rd tier and 4th tier modeling is they're trying to drive people, if they can, out of some of these more expensive drugs into lower cost drug therapies that are just as effective at times. So certainly, one of the reasons why that occurs. Utilization impact, what we're looking at here with the higher copays, we believe that about 300 of the prescriptions are going to be taken out of Tier 3. About 200 of those will go to Tier 1. About 100 of those will go to Tier 2. About 500 scripts will come out of Tier 2 and be driven down to Tier 1. So people will be making different buying decisions based on, I'm paying a lot more out of my pocket, so I'm going to start asking my doctor some questions and see if there's another drug that may be just as effective, either at the generic level or maybe a preferred brand name level. Again, most of this is hypothetical. Some of it is based on true data with the consortium, but trying to keep the numbers fairly simple by rounding them as best we can.
Steve?
Yes.
I know that this is an example and it's helpful to see how you come to this, but one of the things that we talked about briefly at the Own Your Own Health Committee was ProAct's ability to make CanRx prescriptions available at a significant savings. So I know this is an example, but I guess I would like to wonder whether we have a chance to model premium costs that factor in a greater utilization of those lower cost Canadian drugs.
We could. The consortium did look at the CanRx issue, I can't remember how many years ago now. And the consortium's counsel at that time suggested that it was not a good idea because there were still a lot of legal questions about transferring drugs across international lines via a mail order program like that. We could certainly look into it again. We do have one municipality that is using the program outside of the consortium, and they're doing that on their own. But it's something we could certainly look at in terms of the consortium. We would do a similar analysis, look at the impact on a per drug basis. Obviously, we'd have to manage what drugs are available. You certainly don't want drugs available that would be available in the United States generically because obviously, well, not obviously, but as a point of information, generics are more expensive in Canada than they are in the United States, where brand name drugs are much more costly in the United States versus Canada. So we want to make sure and balance that, but it's something we can certainly look at. But we would do a similar equation in terms of looking at, average cost per drug. You look at the utilization of those particular drugs, how many people we think would go through the international mail versus the traditional drug program, and we could certainly do some modeling. And I know PROAC's got a lot of data because they've worked with CanRx over the years that we could utilize for that, but we could certainly do that, yes.
Thanks.
Oh, no problem. In terms of the step-by-step equation, to show you again the kind of the impact that we were looking at with the earlier slides when we showed that impact in terms of rate. This is similar to what we'd be looking at. So we've got tier 1 copays. We got 62,000 of those. We're increasing that by $5, so it's 310,000. We're increasing our tier 2 copays. We've got 9,600 of those at $10. We've got tier 3 copay going up by $10. We've got 3,900 of those. We have 200 drugs going from tier 3 to tier 1. We have 100 drugs going from tier 3 to tier 2, and then we have 500 going from tier 2 to tier 1. Collectively, all that adds up to about $806,000. We know that our premium is $37.3 million. We know that 27.8% of that is drug, so that gets us to the $10.369 million in overall premium. $806,000 divided by 10.369 comes up with a premium differential at 7.758% in terms of reduction based on this particular modeling that we would be doing for this change, going from 515.30 to 1025.40 for a traditional 3-tier drug program. Again, just an example of all the different elements that would be involved in that type of equation. Wellness, a little bit different. One of the things that we talked a little bit about just a second ago with wellness is that, there's a short-term and long-term strategy with wellness. We know there's an upfront cost associated with wellness. We also believe that there's a long-term benefit associated with wellness. At least we certainly hope there is. From all the data that we've been able to look at, suggested there certainly is. So we did want to show some information relative to the cost impact of Blue for You, because I know that the Own Your Own Health Committee has been looking at this as well in terms of maybe potentially offering the Blue for You as an add-on to our existing programs. So we did take a little look at this just to see. This is, first slide assumes a very aggressive marketing campaign, which would include some incentives for people to use the Blue for You program. We've been advised that a good assumption to use for that is about 30% of the population with incentives would probably use the Blue for You program. So in terms of looking at the dollar impact for an individual plan, cost-wise, it'd be about $3.75 per contract per month if this was offered for the entire population, and about 30% of the population used it. It'd be about $11.25 impact per month on the family rate. And you can see what the cost impact of that is. It's 0.534% on individual, about 0.617% on a family plan in terms of rate differential from a cost perspective. We also took a look at what it would be, without incentives, with just some light marketing of the program. And we usually, a percentage there of about 10% of the population would actually utilize the wellness program to its extent. And as a result, obviously, with less population using the program, the cost comes down. Then we'd be looking at about $1.25 for an individual, about $3.75 for a family, roughly. And again, the impact of those are far less than what it would be with a incentive-based program with aggressive marketing, less than 0.2% premium adjustment to offer the Blue for You wellness program. Some of the factors that we would consider in whether or not this makes sense to offer, and some of the things I think that the Own Your Own Health Committee has been weighing. You know, obviously, intuitively, we all think wellness is a smart thing to do. We think it'll help people be healthier longer. It certainly would help the plan in terms of avoiding some expense. So from an intuitive perspective, it certainly seems to make a whole lot of sense to add this type of program. The immediate benefit in terms of quantifying the impact is very difficult to do. Wellness, you know, if you're talking about people living a healthier lifestyle, eating better, you know, doing those types of things, those are more long-term types of analysis. You want to look at that over 5 or 10 years to see how that's affected the population. Going from year to year going to be very difficult to quantify whether or not wellness has helped or hurt the overall equation. In terms of long-term benefit, you know, obviously we're not going to know that for some time. We're going to have to do some analysis and report back, and we may be 5 years into it and find out that, it was a good idea, but maybe it didn't return what we thought it would return. Reporting return on investment has to be substantive. It has to lower overall medical and prescription drug claims. We want less worker absenteeism, increased work production, lower disability and workers' compensation claims. I mean, that's what you want to see in terms of your return on investment with a wellness program. You want to see impacts across all those line items. So when you're looking at it from an employer perspective and everything that we read and we hear from the experts in this particular area, is you kind of have to look a little bit beyond just the impact on health insurance premiums and cost. You really need to look at some of these other things too and see if it has an impact. And that's where we'd have to rely on the employers to give us information back to say, yeah, you know, since we put in the wellness program, we've gone from 100, you know, sick days in a given year, we're down to 78 sick days. Now, it could be anecdotal, but if you see a trend over several years, all of a sudden you may be able to say, yeah, you know what, we think that the wellness program has had some impact on our population and has some impact on our overall costs from an employer perspective and our efficiency from an employer perspective. Excellus has told us that the differentials that they use from the voluntary, no incentive-based, very low tone marketing effort of about 0.5% on premium, reduction to about 3% on total premium for extremely aggressive, high incentive-based type programs. Those are the factors that they're using across their book of business for those plans that have wellness versus those that don't have wellness. So they are showing it as a cost reduction at this point. So with that, before we get into the next section, I know Don wanted to break here for a second.
Yeah, so this is part of our wellness initiative to get up and stretch. So Michael's going to stand up at the far end up there and take a picture of all of us together. This is for our newsletter, and it's a picture of who we are. So it's a mix of all the different municipalities. So if people would come down to this end, just briefly for a photo, and then there's a chair here as well. And behind us, if you come in, so we can get everybody in the picture, that'd be perfect.
Yes. Okay, that looks pretty good. All right. No exciting. All right, here we go. 1, 2, smile.
All right. Still trying to get you out of here in a half an hour, so we'll try to get through these last few slides fairly quickly. Now, in terms of, you know, what we can and can't change in terms of benefits, I think it's important to kind of recap a little bit of you know, what we're required to do from a benefit perspective as a municipal cooperative health benefit plan under Article 47, subject to New York State insurance laws, because that's kind of important to have an understanding of, you know, kind of the basic elements that we do have to provide, and just kind of a refresher on, again, what kind of restrictions we do have relative to benefit options and things we can speak about. So in terms of New York State, we do have a bunch of minimum benefits. It's not going to mean a lot to a lot of folks. But suffice it to say, being in New York State, we're always subject to enough, if not more than our fair share of regulatory oversight, and this is no different. We have a number of insurance laws and regulations that we have to adhere to in terms of developing our benefit plans. We do have to have everything approved by the State Department of Financial Services. So all of our plans have to go through their vetting process. So it's quite a daunting task in terms of putting together a benefit plan and those elements that we can and cannot change. Predominantly, you know, when we talk about different benefits that we can change, we're really talking about the member's cost share part of the equation. Under the federal law, we do have to comply with all the Affordable Care Act, minimum essential benefits. So not only do we have New York State's minimum benefits that we have to adhere to, now we have the Affordable Care Act's minimum benefits, and those are pretty substantive in terms of their impact on our overall plan design and things of that nature. In addition to that, we have a myriad of state and federal mandates. These are laws that have been passed over the years. Predominantly, most of them have come on since 2003. We've had 51 new benefit mandates since 2003. A lot of them had to do with the Affordable Care Act and changes that the state had to make to comply there, or to conform their regulations with the Affordable Care Act. But suffice it to say, it's a pretty challenging process just to keep up with all these regulations and all these mandates. Just to kind of give you an idea of the ones that kind of impacted us more recently, the ones highlighted in red here were recent changes because of the, either because of the Affordable Care Act or because of some recent changes in state law. All of these have been within the last 10 years, but the oral contraceptives, the routine physicals for adults, bone density testing, chemical dependency, both inpatient and outpatient being treated like medical in terms of limitations, contraception, New York State dependent age 29 coverage, healthcare reform, the dependents covered age 26, New York State same-sex marriage, the removal of any annual maximums. You know, we can go on and on. There's no longer any waiting periods for coverage, you know, and there's no pre-existing conditions. There's all these different things that have been added to the program over time. And these things do impact, obviously, what happens from a rate perspective and from a budget perspective in terms of the overall health insurance plan. And just to give you an idea of impact, this happens to be a study that we did for one of our groups. It's a school group up in the Plattsburgh area. It's 17 different school districts. I think their annual budget's around $50 million, somewhere in that ballpark. A little hard to see the colors on the screen, but the upper line, the blue line, that's all their dependents age 18 and younger, their monthly claims. And you can see in that age group, it's very volatile. Whenever you have a significant loss, it really spikes the equation a lot. And then the dependents over the age of 19, you can see their losses. Now, the dependents under the age of 18 or 18 and under, as you get to 2012 and beyond, their claims kind of stabilized. It maybe went down a little bit. Whereas the reverse happened with the over 19 population, their claims spiked up and continued to increase because there's now kids being covered all the way to age 26, where they used to cut it off at students up to age 23. So, you know, more bodies, more cost. The overall impact was about a 2 to 4% increase per plan in terms of what overall dollar amount was paid year to year for this particular segment of the population versus what they paid in years prior. So a meaningful impact from a mandate perspective. In terms of what can be excluded, we can have some exclusions under the plan still, although they're quite limited from what they used to be. These are just a list of some of the more common ones that state insurance law allows. and the federal insurance law allows. But certainly, the ones that people run into the most are probably cosmetic services, things that aren't medically necessary or not medically necessary. Those are probably the two most common, maybe experimental investigational as well. And obviously, if you have no fault or workers' comp claim issues, those aren't covered under health insurance either. I also want to talk a little bit about the metal level plans, because the way these plans operate and the way that their rating is from year to year, it's quite a bit different than our traditional plans. And I just want to give a little bit of a refresher on these as well, because I think it's important to understand the difference, because in 2017, we're going to be making some adjustments to the metal level plans, and their rate may be adjusted differently than the base plans in the consortium as a result of that. And we just want to touch on that a little bit. So the metal level plans, again, just as a quick reminder in terms of cost impact and what it means. These plans are established via an actuarial value computation, with the platinum plan providing a benefit equal to about 90% of the average person's medical care costs and prescription drug costs in a given year. The gold plan at 80%, silver at 70%, and bronze at 60%. Now, the guarantee with these programs is not that you're going to always have a $10 copay, or you're always going to have a $100 emergency room copay. The guarantee here is that the actuarial value will always be at these levels within a standard deviation or plus or minus 2%. So that's the goal of these programs over time, and that's what we're trying to maintain as we move forward with these programs. Again, the platinum and the gold are very similar to a PPO design in terms of its operation. Silver is still very close to a PPO, but does qualify as a high deductible health plan, and the same thing with the bronze. In terms of limitations for 2016, every year the federal government says, okay, this is the level that your maximum deductible can be, this is the level your maximum out-of-pocket can be, and they set those every single year. For 2016, the most that an individual deductible can be is $6,550, and that would be bronze level. The most the family deductible could be is $13,100. Same thing with the out-of-pocket maximum. So the maximum anybody could pay out-of-pocket for in-network services under any plan that would qualify for minimum essential benefits would have to be at or below these levels in terms of out-of-pocket expense to the member. The member's cost share has a lot to do with the actuarial value. Obviously, if the deductible is high, the actuarial value is going to be lower. If they're paying a lot in co-insurance, which is percentage-based payments, again, that's going to impact the actuarial value. Any medical copays that are paid, like a $15 primary care physician copay or a $30 specialist copay, those all impact the actuarial value. Prescription drug, even though it's only about 28% of our total claims expense, obviously the copays associated with those, because of the number of services involved and the number of scripts that are filled every year, have a big impact on the actuarial value, more so than the office visit copays. Out-of-pocket maximums have a pretty large impact on the actuarial value, as does out-of-network provider balance billings. That's obviously more of a member impact than an actuarial value impact. And then those services that aren't covered or those products that aren't covered. I did put a couple examples. They're probably going to be hard to see on the screen here of the actuarial value calculator in operation. The first one has to do with the gold plan. And this was done, I think, last year. Just an example, it showed at that time that we were at 82.4% actuarial value for our gold plan, which is not supposed to exceed 82%. So we were already outside the limit last year. But this shows you the different elements that are involved in terms of the calculation. Deductible probably being the tantamount. Yes?
Yeah, I think it's important here to note, and maybe you will, but the amount of check boxes that we can control are how many on that whole thing? Like 2?
Yeah. Actually, we control almost all of them except for outpatient facility fee. You can't have a cost share with that.
But you can't, the type of benefits, you can't touch them.
No. The types of benefits are set. The only thing you can touch is the level of deductible, co-insurance, or copay. That's correct.
Yeah, so I mean.
Yeah, you cannot adjust. This is the model developed by the Centers of Medicare and Medicaid Services, and we do not get the ability to add or delete any of the medical categories or any of the drug categories.
I think it's real, from my studies of this, it's critical to note that since we can't change the type of benefits,
and that's really
those things, those are what the bulk of our costs are.
And that's really a good point. Today, if you look at most benefit plans today, and if you line them up side by side, in terms of the actual benefits that are provided, they're all the same. Everybody's providing inpatient hospital. Everybody's providing inpatient psychiatric, same thing as inpatient hospital like medical. Everybody's providing office visits. Everybody's providing all the same types of coverage. The only things that vary is how it's paid for. How much does the member pay in deductible or co-insurance or copay? Those are really the only elements that vary. All of these things that you see up here on the left side under types of benefits are the same under every single program today.
Right, and we talk about wellness on our end, but we kind of need a wellness for the type of benefits as well. We don't have it.
Yeah, over the years, it's kind of interesting. If you ever, I've been in the business too long probably. I know some of this, but over the 30 years I've been in the business, it's kind of been interesting to see the evolution of health insurance, what it is today versus what it was back in the day. 20 years ago, for instance, for psychiatric services, for outpatient psychiatric services, you were limited typically to 20 visits in a given year if you wanted to go see a psychologist or psychiatrist. Today it's unlimited. You can go every day if you want to. And with psych, it's hard to determine whether or not it's medically appropriate or necessary or not. There's no X-ray that says that you're healed or not. It's just interpretation. So that's a lot different than it used to be. You look at things like, my father had 2 knee replacements a few years ago. 20 years ago, and we didn't have any. There weren't any. They didn't exist. You hear about people having lung and heart transplants. Again, over the 20 or 30 years I've been in the business, those didn't exist. So finding out, just kind of seeing the evolution of what's happened over the years. Now we cover, there's not much that's not covered under health insurance today, quite honestly. There's very few variables left that you can pick and choose from to say, I want this and don't want that.
Right, but that's kind of where we need to head with this. Otherwise, this whole system is in a death spiral otherwise. That's kind of how I look at it. There's no two ways about it. We're not going to be able to continue to eat more of our salary with healthcare costs indefinitely.
And that one of the things that the Affordable Care Act didn't do, and we're still waiting for someone to do, is really address the cost of care aspect of it.
That's right.
Until somebody comes up with some kind of modeling to address that. And, Medicare and Medicaid have done their own thing on their own end, which has actually driven up our costs because they mandate what they're going to provide to the hospitals and the physicians. And as a result of that, they keep giving them less and less, and it forces more because they're looking to recoup revenue. So that's going to force more into the insurance plans. So we end up paying more because of that. So until somebody does address that on a reasonable level, it is going to be difficult. We're going to continue to go through this process where you're negotiating to lower benefit levels in order to try to get savings. And that's difficult, obviously. You're talking about, some people that work a lot of municipalities don't make a lot of money. And they really can't afford some of these lower end programs with more reasonable premiums. So it does become a very difficult equation as we go through this process.
Anyway, thanks.
No worries. Yep. So when you look at, for instance, this gold plan here, you see that, $500 deductible, you see $250 copay for ER, and some pretty high level copays, and that's how you get to that 82.4%. The other example that we had was the Platinum plan, and again, we're showing it at about 95%. The Blues did their calculation about 94%. Still trying to reconcile some of that. But, when you don't have the upfront deductible, you have a lot of paid in full, a lot of zero copay, you see there, et cetera. It's going to be obviously a much higher level of benefit associated with it. This is something I want to talk about because we are going through this process now, and it is germane to the whole discussion about premium. Maintaining a plan's actuarial value and the steps we're going to go through this year to do that. Basically, we're in the process now of identifying or setting the baseline for each plan's actuarial value. We're going to be making whatever changes we need to make on January 1st of next year in terms of the benefits that would be changed. The board of directors are going to have to approve those on or before November 1st, hopefully before, in terms of the changes that would occur. They'll be communicated out to the membership sometime in December or November. We're hoping November. And we're going to adhere to the following definition for the actuarial value. Again, talking about the calculator and the different levels of percentages that we have to meet. And then the system that we're going to use to calculate it, we're still using the CMS calculator for now. If it doesn't exist at some point in the future, we're going to use an independent actuary to develop the process. I can tell you that we've started to have discussions with the Joint Committee on Benefit and Plan Structure. And one of the things that we started to talk to them about was the actuarial value for the Platinum Plan. Excelis determined the actuarial value of the current Platinum Plan to be 92.6%. We came up with a slightly different number, and again, we're going to reconcile that with the Blues and verify where our starting point is. We know that we have to get within a range of 88 to 92%. That's our goal for 2017. Obviously, if we want to stay at the higher end, it's a minimal change, 0.6%. If we want to get somewhere down around the lower end, it's pretty meaningful at 4.6%. I think our goal is going to be somewhere in the middle, and maybe hope to have some kind of a benefit change this year and maybe avoid it in 2018 and then have another one in 2019. But we'll see what the consensus of the Joint Committee is in terms of what their recommendation will be. And like I said, we're going through that process right now with the Joint Committee. We're hoping to have a more meaningful discussion in our next meeting, which is June 2nd, I think. Whatever the first Thursday in June is. So we're going to be having a pretty in-depth discussion at that point in terms of options and what we're going to be looking at. We did share with them the last time we met this list to kind of give you a feel for premium impact and different levels of benefit that we're looking at changing. And these came from some recommendations that Excelis had based on their modeling. So the first one is increase the primary care physician copay from 15 to 25, increase the specialist copay from 25 to 40. That would be the only change. And that would return a value of about 1.6% reduction. And then you can go through the list and see what some other things would be. We could add a copay to diagnostic lab under number 3 as an example, a $25 copay. We currently don't have a copay for that. A lot of lab services are rendered during the year, so they would impact a lot of people. It's only one benefit that would change, but it would return about 1.55%. Or you could go all the way down to number 6, increase primary care physician copay, increase specialist copay, and add the lab. And now you're talking about 3.82% actuarial value differential. So, there's a lot of different ways to manipulate this to get where you want to get. It's a matter of what everybody feels comfortable with. Do you feel more comfortable with adjusting the out-of-pocket maximum, the underlying copays, somewhere in between, maybe a little bit of both? And we're just going to go through that process with the committee, see what they feel comfortable with, see what they would want to recommend out. Our goal is obviously we're still going to look to maintain only one plan at each metal level going forward. And you'll just continue to have that being our option. We don't want to get into a situation where we've got 5 different platinum plans, all returning basically the same actuarial value. It really doesn't make a lot of sense to us if at the end of the day, they're all providing about a 90% benefit differential. In addition to that, I did want to turn it over to Don to talk a little bit about the consortium's vision on wellness, because that is something that we are talking about possibly adding to some of the benefit plans, and will have an impact on rate going forward as well.
All right, thanks, Steve. The mission and vision statement that the consortium board has adopted states this about the wellness. Health Insurance Consortium promotes the culture of preventive health care for the well-being of its members. So in doing that, we have the wellness vision, and this is the vision statement that was put together with the work of the Own Your Own Health Committee. So wellness serves us individually and collectively. Individually, when we're well, we feel good and we're ready to get at the day, and collectively, it reduces the cost. And in 2015, although it was not a result of a wellness program, you see what happens whenever we are well and we don't have any major losses. We have significant reduction in claims cost. So each employer and group establishes their own wellness plan. There's not a consortium wellness plan, but the consortium does have some actions and levers that it can pull. We do have the newsletter that we're working on, and we advocate for strategies that individuals can take to reduce their health care costs. We also have the Joint Committee, and we have lots of discussion about wellness and the utilization reports from both Excelis and PROACT that help us understand where our cost centers are and how they're being used by the members. And then we also have created the flu clinics that happened the last 2 years. So the consortium does have some levers to work on, but most of the wellness is going to have to be done by the municipal employers, and we have 20 of them right now. They will not all be working in concert, but they can be working towards a wellness program. So wellness is a benefit of the meta level plans, and it takes place through the Excelis Blue for You program, which you can find on our website as well as at Excelis. And this involves a biometric screening so that people know their numbers. And oftentimes people think they're very healthy and they find their numbers and they learn that they're not. And that's exactly who we're trying to gather in this, because now we can treat them for pre-diabetic conditions or cholesterol before it ever becomes a real health issue for them. And that's what's so important and effective about this program. In addition to biometric screening, there's also wellness coaching, so that even if you are well, there probably are things that you can do to be helping yourself be healthier. We did have the rollout in Cortland County. We did that in March, and we're looking for Tompkins County and TC3 this summer. We had to find a location that could do the biometric screening in Tompkins County, and Excelis has made that happen, so we can proceed with that. And wellness is really the mechanism that we have collectively to manage claims. There's really no other mechanism. Everything else we're talking about has been financial. So wellness is a real action that we take individually and collectively. I would just say the Own Your Own Health Committee meets on the third Wednesday of each month at 1:30, and we'd love to have more participation because this is something that we do together, and love to have your input.
Except for me.
Excuse me?
Except for me.
Except for you?
No, May.
Oh, except for May, right. So you can check for our agenda on the website, just like you can for all the committee meetings and our meeting schedule and so on. So having said all that, I want to ask if there are any questions that you want to ask right now. Okay. While you're thinking of your questions, there's food in the back corner that you can take with you so you can make it back to your office. And finally, the PowerPoint slides you had were on a three on a page, and you can actually find the full-blown version, which are much more readable, on the website. Michelle will be posting this probably today or tomorrow, so you'll be able to find that information. We'll be talking about this, and not only Own Your Own Health, but all the committees. We're talking about the issues that information we gathered today. So hopefully you'll be better prepared for that. And please feel free to ask questions, because this is you're running the organization, and we need your input, and we need you to understand what's happening and ask the questions so we all can be better prepared. So with that, we have a question back here from Amy. Amy.
I know that a lot of the scenarios were just proposed, many of us are in collective negotiations right now with our bargaining units, and so where some of our contracts have specific prescription payments, if you're proposing to change those, when might we know? And
so actually, we don't, if you're talking about the four of us up here in front, we don't propose anything.
oh, okay, those are just summary examples.
We only respond to our members and the issues that they'd like us to work on. So just an example, Nancy Zaylor brought up about the two-person. So that's something that's not being proposed, but we can investigate it,
Right.
and that's exactly what we're here to do.
Perfect. Okay, I just want to make sure that we don't have to add some special language to the contracts. All right, thank you.
Any other questions? That's a good one. Thank you so much. All right. We still have a few, there are logos up here. Not all the stickers have been put on, so if you have a choice, please do that on your way out, and have a great day. Thank you so much.
Thank you.